Okay, well, let's get started. Welcome everyone to this new series of webinars that we're just starting with Lung Cancer Canada. It's called What's New in Lung Cancer. My name's Paul Wheatley-Price. I'm a medical oncologist here in Ottawa and currently also serve as the president of Lung Cancer Canada. And the goal of these webinars, which we'll be doing about once a month or so, is to inform people who sign in to listen to the webinar, or indeed we're live on Facebook as well tonight. What's the latest news, a bit of education about a specific aspect of lung cancer, and then there'll be an opportunity to ask questions. So this is our inaugural meeting. We've got another one scheduled in early December, which is going to be about ALK lung cancer. And for that, our guests will be Dr. Ross Camage from Colorado and Dr. Natasha Lale from Princess Margaret Cancer Center in Toronto. You can see on the screen is myself, and then Christina Sitt, who is our programs manager at Lung Cancer Canada, and she will be coordinating our question and answer session a bit later on. But I'm thrilled to invite in our inaugural What's New series two colleagues from around the world who really need no introduction. They are, extremely well known and respected. So firstly, Dr. Barb Melosky is a chair of medicine in Vancouver. She's the head of the lung cancer tumor group for British Columbia and the long-standing chair of the Canadian Lung Cancer Conference. And then Professor Tony Mok, who is professor of clinical oncology at the Chinese University in Hong Kong. And Professor Mok trained in Canada, and he has been really a lead researcher in EGFR lung cancer for many years, and we'll tap into some of that knowledge soon. He collaborates with researchers in China and Hong Kong and indeed around the world, and is a past president of the International Association for the Study of Lung Cancer. So without further ado, welcome to both of you. And we're going to get straight into this. And the way that we're going to do it is I'm going to ask questions of Professor Mok and Professor Dr. Melosky, and we'll kind of go back and forth. These are questions that I've come up with in collaboration with my colleagues. And we've also already received a number of questions from you, and we'll get to those somewhat through the discussion and then at the end in our Q&A session. If you do want to ask questions, there's a chat box or a Q&A section at the bottom of your screen. You can just click on that to put your questions in. So the topic of today is EGFR lung cancer, epidermal growth factor receptor lung cancer. And so the first question is, Professor Mok, could you tell us what exactly is EGFR lung cancer and who gets it?
All right, before that, call me Tony. Come on, let's do it the Canadian way,
okay,
all right? Don't call me Professor so-and-so, I mean, Paul. All right, the way I always explain that to the patient is that it's just like your cell phone. In your cell phone, you need to receive signal from the surrounding station before you can hear it. So the EGFR is actually a receptor, receive signal of the cell. So all cells have to get the signal to grow, which is to receive the growth hormone receptor. So once you receive the signal, then you get a whole signaling pathway inside the cell that tell the cell to grow faster, grow bigger, and those kind of stuff. So it is actually a receiving system. However, once it got mutated, the signal become continuous. So instead of just grow when you only receive signal, it grow continuously. So as a result, it becomes a cancer cell.
Okay, so I like that analogy. I've not heard that before with a cell phone. Can anybody get this? Is it what type of is it hereditary? Can you inherit it from your parents, or is it who gets it?
So first of all, this is what we call the somatic mutation. So let me just clarify the term. It's a little bit complex term. There is so-called a germline mutation and a somatic mutation. Germline mutation is something that is inheritary, that you can get, and then those are the mutations that occur in all the cell in your whole body. So one mutation will go for the whole body. That's the germline mutation. But somatic mutation only happen in the cancer cell. So in a sense, is that it's not a mutation you can inherit it, you can pass on, because it only happened inside the cancer cell. How did it happen? I don't have a good explanation. Now, EGFR basically take place in many cells in the body, skin cell, hair, guts. And why would the cell in the lung will get mutated? That actually is still a million-dollar question. Why do we have it more common in Asia than the Caucasian population? That is still a mystery. We have already done what we call the whole genome sequencing, meaning that to study the entire genome of hundreds of patients from Asia and United States, and we cannot find a solution to answer this question. So we don't know. That's to keep the answer simple. But then it occurs, and then more frequently in the Asian population than the Caucasian population.
Okay. And I guess one final question on this point, is EGFR lung cancer, so it's the somatic mutation, you can't pass it on or catch it from anyone. Is it associated with cigarette smoking or tobacco exposure?
So interestingly enough, this is one lung cancer that is not related to tobacco smoking. Our original observation is this: in the Caucasian population, the percentage of non-smoking lung cancer is about 10%, compared to the Asian population had always been 30%, and we cannot explain that. And now we know that the patient who are actually non-smoker with something what we call adenocarcinoma, the gland type of lung cancer, they are the one with the highest incidence of having the EGFR mutation. So therefore, it is a mutation not directly related to tobacco exposure.
Okay, great. Thank you. So I think that sets the scene. And now, so we're on first name terms then. So Barb, first question.
You can call me Dr. Melosky.
Dr. Melosky, mom. Maybe could you just walk us through a little bit of the history of EGFR lung cancer? When was it first discovered, and you know, that a little kind of sweep through time for us.
It's such an interesting story, mostly because when I've lived through it, and I'm thinking back to the early sort of 2000s, so 20 years ago, and I remember AstraZeneca giving us gefitinib just to try out, and we didn't know how it worked. We knew that it was an oral pill. We knew that when we were giving it to patients, that some patients did incredibly well with it. And I remember even a patient waking up in the ICU with Gwen Bevs, but we didn't really know why it was working. And it wasn't even clear that it was, like Tony said, the non-smokers. And in about 2004, 2 papers came out really about the same time. And both papers suggested that in 10 patients here and 10 patients there, if you had a mutation, these were the patients who were responding to gefitinib. And I remember going into my mentor's office, Dr. Nevin Murray, and saying, gosh, now we'll know who to give it to and who not to. But we then argued as a thoracic community for about 4 or 5 years. You know, I think, Francis Shepard, another mentor of mine, as a Canadian, we all supported that maybe it was sort of the outside of the cell, what was called IHC. Fred Hirsch from Colorado was arguing that it was a number of sort of copy numbers, what's called FISH test. And it really wasn't until Dr. Mock's sort of study came out called IPASS that, the light bulb went on. It was really that simple that, in a retrospective analysis, he showed that the people that were most responding to the gefitinib were the people with mutation. And that changed our whole lung cancer world. It really did. And, hats off to you, Tony. That was really, I think all of us, all of a sudden it was like, of course, like we all then accepted it as a community. There's no more fighting.
Barbara, I always thought that when this story broke out, you were in high school. So now you tell me the truth.
Well, I do think I am a bit younger than you, but I'm not sure how much.
Well, I might have been in high school. So I was doing my residency when that paper that you mentioned by Dr. Lynch was published in the New England Journal of Medicine in 2004, which, and the New England Journal of Medicine is maybe the premier medical journal in the world. And normally you have to have a big fancy study to go into the New England Journal. And Dr. Lynch published this paper with 10 patients reporting that if the EGFR mutation was found, as Tony had described, that signal that was continually switched on, if you had that mutation, then the gefitinib worked. And then that led to, well, I guess maybe Tony, I'll come back to you, because that led, I guess, to the IPASS study, which is the famous study that changed what we all do, that you were the lead of. Maybe you could tell us about how the story, kind of pick up the story from Bob about how
Sure.
this drug gefitinib became the EGFR drug of its time.
Yeah, no problem. I think it's also a fascinating story. First of all, I was at the audience when Tom Lynch presented that in, I think, ASCO, that he was actually presented that. I was in the audience. I just say, wow, this is the jackpot. This is really going to change everything we do for lung cancer. And also about the same time, the group from the NCI had published a paper showed the incidence to be extremely high in the Asian population, as well as Dr. Mitsutomi's group also demonstrated that in Japan, they had very high incidence. So it became very clear this is going to be a disease that is more prevalent in the Asian population. So let's go back a little bit about the gefitinib story, like what Barbara had said. So at that time, gefitinib was given to all lung cancer patients, and only retrospectively they find this mutation. But interestingly enough, at that time, because of the dramatic improvement, FDA had given a conditional approval to AstraZeneca to make the drug available to all lung cancer patients, despite of mutation status, because they didn't know about mutation status before. So the drug get a conditional approval available in the United States, but they have to promise FDA to do 3 studies. One study that is actually going to compare with the placebo in the 3rd line. The second study is to compare with docetaxel in the 2nd line. And then the 3rd study is to compare with doublet chemotherapy in the 1st line. And all 3 studies has to be unselected population. That was the original design of the 3 study they promised FDA. But turn out the study against placebo totally negative. So as a result, they have to withdraw gefitinib from United States. So they actually did not have gefitinib in the United States for the next 10, 15 years. Originally, the IPASS study in the 1st line situation was supposed to be led by Ron Natale in UCLA. And then I was supposed to be the Asia collaborator, quote unquote. And so, but then they have to withdraw that I become the leader of the study. So I was handed this protocol saying that 1st line comparison head-to-head off selection party, every patient can come in, and then the primary endpoint over survival. I look at that, I say it's going to be a negative study, because we already knew that actually EGFR is the driving force behind. If you include every patient and you have no control of who's coming in, then you really have no idea how the distribution is for the randomization. And also due to crossover, over survival will never be a primary endpoint of choice. So I have a lot of struggle. So we designed the whole study to enrich the study, since it's going to be Asia, to enrich it to say non-smoker, adenocarcinoma. And so that will give us the highest incidence of EGFR mutation. And then we insist to get the sample as much as we can. At that time, remember the good old day, getting sample for lung cancer study was very difficult. Yes, you guys in high school, you don't remember. But those days, getting sample was not a routine. But then we take a good effort. And also most important of all, change the primary endpoint to progression-free survival. Now, at that time, FDA would never accept progression-free survival as the primary endpoint. And for a very clear reason, they always want over survival. But since FDA is not going to deal with it, we just need to deal with the Japanese and the Chinese authority. So we managed to change the primary endpoint to the progression-free survival.
And Tony, just to clarify here, when you say unselected, that means anybody can go in.
Anybody.
And progression-free survival, for those who aren't familiar with the clinical trial terms, is the time that you're on the treatment until it stops working, as opposed to overall survival, which is our life expectancy. Is that, yeah, okay.
Absolutely,
All right,
absolutely.
so
Yeah.
back to you.
So
So you've got the study going now.
And then that's how we kick off study in 2005. We managed to have China, Japan, and majority of Asia. We enrolled a total of 1,200 patients, and then mostly concentrating retrospectively on the subgroup that we have sampled to look at the EGFR mutation status. And we find in the mutation positive patient, the gefitinib is a lot better than the chemotherapy. And then on the other hand, the group that without the mutation, chemotherapy is a lot better than the gefitinib. So that is actually how we establish the concept of personalized medicine according to the genomic profile of the patient.
Yeah. And for those of you listening in, for those of us who were watching Tony and leading this study, this was, like you, I think, just suggested there, this was a sea change in maybe not even just lung cancer, but in a lot of oncology, looked at this particular study and said, wow, you have a mutation and you can target it with a drug like gefitinib. It's way, way better than chemotherapy. But if you don't have the target, there's no point in having that drug. It won't work. And so this whole concept of targeted therapy, personalized medicine, precision medicine, all stemmed a lot from this study. And then I guess hot on the heels of that, Tony, there were then 5 or 6 studies which really showed the same thing as your IPAS study with other EGFR drugs. Maybe Bob, I can come back to you. So what are the other EGFR drugs that came along either alongside or shortly after gefitinib?
Well, I want to first off by saying, Paul, that BR21 was a Canadian trial, and we showed that there might be some activity of these TKIs, even if you didn't have a mutation. It's certainly not as grand as if you have a mutation, but I'm still a strong believer in BR21. In fact, I saw a patient today who did not have an EGFR mutation and who's responding, and it's likely we missed the EGFR mutation because he's responding extremely well. But going back to your question, and everyone knows that I love choices, and we've got choices these days. We have first generation EGFR TKIs, gefitinib and erlotinib. We have second generation EGFR TKIs, afatinib and dacomitinib. And we have third generation TKI called osimertinib, and a lot of third generation TKIs that are up and coming. So the list continues to grow, our choices continue to grow, and I like choices. I think that osimertinib in the FLORA trial showed that it was superior to those first generation TKIs. I think afatinib is the choice for uncommon mutations. There's still part of the world that believes in this sort of idea of sequencing. And finally, brain mets is sort of a big topic. I think the largest amount of data is for osimertinib, but I've seen responses in brain with all of these agents. So I think I'm pro-choice, and I think osimertinib is probably the easiest drug, but I like to have conversations with patients, and I like the patient to make that decision with me.
So I'm going to pick up, Bob, on just 2 or 3 things that you mentioned there, and we can maybe just tease them out a little bit. So you mentioned this something called the FLORA study, and that osimertinib. Maybe you could just explain when was the FLORA study? When did that come out, and how has that changed things for some people?
The FLORA study, again, looking at first line osimertinib versus most of the other patients were gefitinib, sort of 2/3 gefitinib, 1/3 erlotinib in the first line setting, and the response rates were not that much different. In fact, they were about 80% in each of the 2 sort of groups, but the progression-free survival was 18.7 months in the osimertinib trial versus about 9 or 10 in the gefitinib, which is usually what we've been seeing. So clearly superior to those. And this came out a couple of years ago, and overall survival was positive as well. So, and the brain mets were being controlled, and there's even some of those brain mets had complete response. So I think it was a really good trial. It really showed me that in any patient that you are thinking about using gefitinib, because there's many patients that think of that, then osimertinib is the answer.
Maybe we should just I feel like with one of your answers, maybe we've missed a spot getting to this point when you said that about 80% of people responded. And Tony, you said with the IPAS study that, you know, the gefitinib was clearly superior to chemotherapy. Maybe, Tony, could you just quantify that for people? You know, I say to people in the clinic, if they have an EGFR mutation, that compared to chemotherapy, the tablet treatments are twice as likely to work, and they're likely to work for at least twice as long as chemo would have, with half the side effects. Is that fair, or would you say it's even better than that, or not as good?
I think you can say that, but now that I think most patients already accepted the fact that, you know, chemo is really not the choice. So I don't even compare to chemotherapy anymore. I think that conversation probably is gone. Okay, I just say that, hey, you got 70% chance that your tumor is going to shrink dramatically nice. 20% has some shrinkage, but not as good as I like, but maybe 10% that doesn't do well. So that is a general feeling, because that is according to RECIST criteria, which is the criteria we say with more than 30% reduction of the total sum. That is the quotation that we have. However, there are also 20% of minor response that sometimes we don't tell the patient about minor response, but to the patients physically feeling, they actually feel better. And that is only about 10% of the patient or less that then they don't really respond. So I think that gives them really the confidence that they go on. And I don't usually talk about the median duration. I just say, hey, life go on. Let's just keep this on as long as we can. I can give the statistic, but who cares? I mean, as long as can get you back to normal life, and then I would do everything we can to maintain that. And then also, if it didn't work, I'm going to find another solution for you. Okay. So I don't really try to quantify as much unless they really push me to it. Most patients don't really want the quantification.
Right. And I guess it's different for everyone.
Yep.
But Bob, let me come back to another point that you made, because you said that you like to use afatinib in uncommon mutations, which made me think that we haven't actually discussed that. Tony at the beginning talked about EGFR as being the cell phone with the signal coming in normally, but when there's a mutation, your cell phone is just on all the time. But with uncommon mutations, I guess, could I try and expand the analogy here that, you know, the common mutations might be your iPhone and a Samsung, but there's also some old Nokias out there, and there are some other mutations. How would you describe this? Or could you tell us a bit about the range of mutations that exist?
Yeah, I think I'm not sure that cell phone analogy, but it's interesting. I'd like to sort of think when I talk to patients and I talk to medical students and we talk about the usual mutations, there's two sort of common mutations. One is called 19 deletion, and the other is kind of a funny word. It's called L858R. And then we have about 10%, and it might be even higher than that. And we call that uncommon, but even at 10%, that's not that uncommon. So I don't think we'd call them unusual. I would just say they're not that common. And, you know, living in Vancouver in the Pacific Rim, my practice in EGFR is huge. And so I probably see an uncommon or a not common mutation 1 or 2 a month. And in those patients, you know, I think the afatinib is the only drug that has FDA approval. It's got a huge database of over 700 patients that have been treated with afatinib with an uncommon mutation. And so that is the drug of choice for those patients. Right. You know, the bottom line is uncommon is not uncommon. And we just have to make sure that we're measuring all the EGFR mutations out there, because if you're not, you'll miss them.
Okay, thank you.
One analogy I will use is the bandwidth. It's not the cell phone type, it's the bandwidth. You know, the bandwidth or the length. So if you get bandwidth of the 19 and 21, that's the common one. Anything that's non-19 and non-21, those are uncommon one.
Okay. So, and I should let you know that Lung Cancer Canada always supports and provides a lot of data and advocacy for getting these drugs into the Canadian market. And all of the drugs that Dr. Melosky mentioned there, gefitinib, erlotinib, afatinib, dacomitinib, and osimertinib, all of them have Health Canada approval to be prescribed in Canada. Depending on which province you're in, the funding might be different. So not all of them are necessarily funded in every province, but most of the ones that your oncologist would want to prescribe are largely available now across the country. Tony, may I come back to you for this next question? These drugs don't last forever, and you know, when people have been on gefitinib or afatinib or osimertinib for a while as their first treatment, generally at some point it stops working. And what do you do then? What does the science tell you?
So cancer cell is cunning, and they have to strive for survival. And Dr. Charles Swanton from United Kingdom had developed a system called the cancer evolution, meaning that how do the cell evolve genetically, trying to gain their survival. And there are multiple mechanisms they can do that. And so as a result, there is a spectrum of the mechanism of resistance. The most common one, if you put someone on the first or second generation drug, the T790M mutation located at exon 20, that is the common resistant mutation. And so that is actually the one that occur in 50 to 60% of the resistancy. And that actually lead to the planned development of the third generation drug osimertinib. So the whole osimertinib drug, when you say one generation from the other, there had to be a so-called a diffusion point. And T790M is the division point between the second and third generation because they change the molecular shape. Instead of binding close to the T790M cell site, they bind to another site called the C797S. This is getting very complex, I know, but those are just numbers. But just say if one girlfriend rejects you, you try to bond with another girlfriend. And then that may work. And so, or you can use boyfriend, I mean, whatever. And so in a way is that, so you bind to a different site so that to get the inhibition to continue. So that's a whole design behind the third generation drug osimertinib is to target the target the T790M. So that is the most common one. And but however, there are a few other ones. I just named the name like the MEK amplification, HER2 amplification, but let's not go into too much of detail. Let the doctor worry about it.
Well, I might get you to go into a little more detail because I think a lot of people listening here who maybe have EGFR lung cancer or someone in their family does, they'll know a lot of this, and maybe at some point most patients will make it to osimertinib, it's otherwise known as Tagrisso, and that might be as their first line of treatment, or it might be because they've had the first generation drug and then this T790M mutation has emerged and they've moved on to osimertinib. But if the osimertinib stops working, what are the common things that you're looking for now? I have a couple of people in my practice who just in the last few weeks, we've discovered c-Met amplification after osimertinib, and maybe you could touch on that or other things.
Sure, no problem. So the two biggest set of data actually come from the AURA3 study, which is the second line osimertinib study that I've done, and the FORA study that Barbara had mentioned as the first line. So at the time of progression, we actually collect the blood sample and we perform something called the NGS, next generation sequencing, meaning that using a genomic sequencing to look at the most common mutation from the blood. And both studies had confirmed that the three most common mutation that you observe at the osimertinib failure is number one, c-Met amplification. I talk about a bit of what it is in a moment, which occur about 19 to 20%. And another one is called C797S mutation, and the third one is called the HER2 amplification. Let's go for the c-Met amplification. Now, MEK is actually an escape pathway. So if you push to the corner, then you just have to find another avenue to escape. MEK is that avenue that you can escape. And so when you escape, the MEK got amplified into multiple copy, so there are more signal to keep the cell growing. So that is the MEK amplification. Why is it important now? It's because we already have some MEK inhibitor in the market. namely the drug called Cametinib, which has been approved for a slightly different indication, but now they are working on the use of this drug for MEK amplified situation when you have the EGFR resistant. So that will be in the near future potential. There's already some study demonstrating the potential use. That's number one. C797S, remember I talked about the one girlfriend and the other girlfriend. C797 is the other girlfriend. So you bind to them, but then they reject you again. So they got another mutation with the C797. And so as a result, it becomes resistant. How to deal with that? That will be leading to the birth of the fourth generation. So there are already some compound in development to target the C797. So like the Blue 945 and some other is on the way, but not quite in the clinic yet, but they are getting there. So potentially we will have a new fourth generation targeted to C797S. HER2 is a mutation that's common in the more common amplification is more common in breast cancer, but we find in lung cancer that if you got EGFR resistancy, then it may also amplify that as well. We don't have an official drug yet, but in the future there is a class of drug called ADC, antibody drug conjugate. So that is actually an antibody which can target HER2, and they kind of link a cytotoxic drug, a chemotherapy into it, and zoom it into the cancer cell. So almost like a magic bullet. And those kind of concept is actually available. And HER2 is actually the drug that is approved for breast cancer, HER2 positive. And potentially in lung cancer, they are starting a study as well. So right now we're at the edge of having solution for the selected patient with the molecular changes after osimertinib. Right. As I stated that we are working on it, but not quite there yet.
Right, thank you. And I just ask you just for a brief follow-up question, and then I'm going to move to Barb for some other topics. But my question would be, if you're someone with EGFR lung cancer and you're on osimertinib and it does seem to be not working anymore, how would you know if you've got the C797S or the c-MET amplification or the HER2 amplification? How would your oncologist set about finding that out? And is it easily available to find that kind of thing out?
I don't know about Canada's healthcare system, but with money, yes, you can do it. So first of all, you can do plasma-based NGS. There are two ways of doing it. For C797S, you can do a simple one using something called the digital PCR. So basically, digital PCR is a simple PCR based on the plasma protein, plasma DNA that just get multiple copy. The cost is not high, but then you can do only one gene at a time. So you can specifically test for C797S just by plasma, simple test, not too expensive. Or you can go more expensive way to do the NGS of the whole genome profile that will include the C797S. And there are two companies that's approved in the United States available. One is Garden 360, the other is Foundation One CDX. So those are the two that is available, but I just don't know whether the Canadian system will cover it. In Hong Kong, it doesn't. The patient have to pay out of pocket. The other way is to take a tissue biopsy. That means what we call a re-biopsy. In the beginning of the lung cancer, you have one biopsy, but now if you got resistant, we can re-biopsy depending on the site of progression. If it's something in the lymph node, in the neck, it's easy to do. But if it's in the lung, it would take a slightly more difficult procedure, but it's certainly doable. And then the tissue we got, we send for next generation sequencing or simple EGFR mutation testing.
Yeah. Thank you. So, I mean, the answer to what happens in Canada is those tests are sometimes available on research studies at no cost. Sometimes they do require private paying. So actually, the two people I was mentioning with the c-MET, one of them had their test through Foundation Medicine, the other one through the other company you mentioned, Guardant. Let's just put that topic aside a bit, and because we're in the interest of time, I want to move on to 2020. And Barb, in EGFR lung cancer, there has been some big news this year. What's the latest change that's going to impact people with EGFR lung cancer?
Well, I would say that I just want to add, can I go back to a comment about your previous question? So the reason why the patient right now, or the patient is paying, even though we know that we probably need it, is because when patients fail OSI, we don't always have the drugs for that resistance, like C795S. But as we develop more drugs for these resistant mutations, it's going to become standard of care. We made it standard of care to look for T790 after drugs like gefitinib and afatinib. So I think it really is going to be up to us, Paul, you and I, and the rest of our colleagues across Canada to say to our governments, you know, we want to get testing for patients to look for those resistant mutations because we have drugs that we think can help them.
Maybe I can shout out the Faces of Lung Cancer report then, which is, this is Lung Cancer Awareness Month. Check out the Lung Cancer Canada website and the report we released just about 10 days ago, which really talks a lot about the issue of molecular testing. But anyway, back to 2020, what's happening this year?
Well, I think the biggest thing is in patients who have their cancers taken out, so resected lung cancer, and also have an EGFR mutation, extra treatment, we call that word adjuvant, extra treatment with osimertinib, the third generation EGFR tyrosine kinase inhibitor, has shown to be very beneficial. And that's a trial called ADAURA. A stands for adjuvant, just like FLORA, F stands for first line. So ADAURA was presented and I was in the audience, well, virtually, and my jaw dropped. And I thought, you know, the patients were randomized after surgery. Some of them got chemo, some of them didn't, but they were randomized to osimertinib for 3 years or placebo for 3 years. And clearly, when you look at the curves, the patients on placebo relapsed quickly over the last couple of years. And the people with osimertinib have not relapsed as much. In fact, it's probably, you know, 10 to 1. So 10 patients on placebo were relapsing for 1 on osimertinib.
Right.
And more sort of importantly for the patient, many of those relapses were in brain. And that's all I needed to say, I'll go to Health Canada and speak about this. I'll go to PCODER. I want this for my patients. And if I had EGFR mutated lung cancer that was resected, I'd want it for myself.
Right. Yeah, I'm now prescribing it in that setting if I can get it. It's not gone through the regulatory processes yet because the data is so new.
Yeah.
May I challenge on that question is that would you want to wait for over survival benefit? Would the Canadian government ask for over survival benefit before they approve it?
I think with the brain metastases, the answer is no. You know, I think that, well, now crossover is an amendment to the trial, so we may not ever get overall survival. The overall survival may not come for 4 or 5 years.
I'm just going to interject to maybe just give some meat on the bones of that question, Tony. We don't have all the data yet, I think is what is the point for the study. We've got the earliest data, which showed that people with EGFR lung cancer that had surgery were 80% less likely to have a recurrence than if they got the osimertinib than if they were on the placebo. 80% reduction in the risk of a recurrence. But that doesn't mean that they may not recur later anyway, and then could kind of catch up with treatment from osimertinib at a later date. So the question that Tony's getting at is it really improving your chance of being cured, or is having the osimertinib after surgery merely delaying the time that you might have a recurrence anyway? Personally, Tony, I believe it's improving the cure rate, but I know not everybody is yet convinced by that. But what do you think?
Actually, that maybe I share my thought. I actually support Barbara's thought, but then the OS data is always challenging because it takes a long time to come out. So I always give this analogy is that, all right, you don't give it, you don't talk about it, but what if 3 years later, there's over survival benefit? Can you come back to tell your patient, sorry, I missed telling you that? So I think at this moment, we're obligated at least to share the data with the patient and try to make it available as an option. Although we don't have over survival benefit, but there is a reasonable chance that they may be positive. And then we can go back to tell the patient, sorry, you know. So that's the one reason why I think that we should move forward at this stage.
Right.
That's kind of an analogy of going shopping. You might go to
that you know well.
You might go to the. You guys talked about cell phones and girlfriends. I'm going to bring it back to shopping. But
okay,
you know,
well,
I
on the
think
shopping
other
topic, on the shopping topic, Bob, if you go into the department store and you're shopping for your EGFR drug, in when you go in the front door and turn left, and there's your EGFR drugs, and you're picking osimertinib and gefitinib and all of these great drugs that we've been hearing about. But over there on the right, if you walk through the door, there's another sales hall labeled immunotherapy. So a common question that we receive in preparation for this panel, but also probably in the clinic as well, a lot of EGFR patients want to know, well, I hear a lot about immunotherapy, will that work for me? So Bob, does immunotherapy work in EGFR lung cancer, or is it for a different group of lung cancer patients?
Yeah, when I explain it to patients, you know, I say, you know, immunotherapy works in cancers like melanoma, where you get all these carcinogens from the sun. It works in patients, not always, but in patients who were heavy smokers. They have all these carcinogens from the nicotine and the cigarettes. But in EGFR, they only have one mutation. And so the chance of it working is much less. It's not zero, because I have to say, I've had to eat my words. I just have a patient who's responding beautifully on it, and she's a non-smoker with EGFR. So it's not zero, but really, you know, you should try every EGFR TKI you have. You should try chemotherapy, and then immunotherapy. That's my practice anyways.
Yeah, to support that, there is actually a question from the chat box. They're asking what are the cold cell and hot cell in EGFR lung cancer, and asking us to elaborate. I think this will be a good moment. So I don't think Alex Shaw and Jason Gaynor are talking about cold cell and hot cell of the cancer, of the lung cancer cell, but rather talking about the immune environment. So for the immunotherapy to work, you need to have something called a microenvironment for the T cell to go in and infiltrate and kill the cell. However, there are cancer, as Barbara said, without too much antigen. So the immune cell not too interested. So it becomes so-called a cold environment. So not too inflammation going on. As compared on some cancer that is have a hot environment when they have a lot of antigen. So when Dr. Saw and Dr. Gaynor talk about the cold cell and not cell, they are actually referred to immune inflamed environment. And most of the EGFR positive lung cancer are more likely to be in a cold environment. So even though there's a PD-L1 expression, the microenvironment is not the most suitable for the T cell to be infiltrated. And so as a result, so far we've seen the response rate have been around 10%, 15% type of thing.
Okay, so immunotherapy not so good in this group, particularly when you said earlier that the response rates to the EGFR drugs are 70, 80, 90%. So I think we're probably all in agreement that immunotherapy is an option, but it's nowhere near the front of the line for the best option.
Single checkpoint. I think like that world's changing so quickly too, and you know, it'd be interesting in the next few years. We're going to see patients with EGFR where they're trying to change that microenvironment, and
right.
that's where immunotherapy then may work. So that world's really changing quickly. But as of today, you know, with our checkpoint, what we call checkpoint inhibitors, you know, really, I think Dr. Mock also said and made it clear that your marker for responding to those drugs is called PD-L1, and it's not reliable in patients with EGFR.
Right. So I'm going to ask one more question, and then we're going to go to the Q&A session. Last year, I'm not sure if it was an honor or not. I debated at a conference with Dr. Francis Shepard, who was my mentor, and Dr. Shepard is world-renowned lung oncologist and led many international studies from Princess Margaret Cancer Center. And she asked me to do the debate at Princess Margaret, like, so, you know, she was on home turf. And anyway, the question that we discussed was, with EGFR drugs, is it a good idea to have the osimertinib or the gefitinib but try and add something to it so you can really give a sort of double whammy approach? Should you be giving immunotherapy as well, even if immunotherapy on its own is not great? Or should you be giving chemotherapy together with an EGFR drug? Or could you be giving some of these drugs called anti-angiogenesis drugs that sort of starve the blood vessel supply?
Tony,
Paul,
first of all, even I call Frances to be Mama Lung, so don't argue with the mother. But anyway, to your
I hope
question.
she's not watching.
So combine chemo with EGF TKI and combine the anti-angiogenic drug with the TKI have been studied together with the first generation drug. And they have been demonstrating some improvement on the progression-free survival, as you have explained. However, today there's not too much strong data to suggest that it improved the overall survival, because in a way is that the combined treatment can be given subsequently. So at this moment, we don't have tremendous data to support on the use, especially there are potential toxicity, and also with the chemotherapy or the anti-angiogenic drug, you need to go to hospital every 3 weeks. And then like some of our patients go on with the targeted therapy for a long time. So you're asking the patient to commit themselves to come to hospital every 3 weeks for a long time. So whether that's really worth their while for a slight improvement in the progression-free survival is debatable.
Okay.
As for osimertinib, I don't think it should be combined with immunotherapy, because there's one report just indicating there's a very high incidence of something called interstitial pneumonia, which is a very severe form of immune-related pneumonia that can be fatal. So right now, no one will actually dare to use osimertinib and a PD-L1 agent simultaneously at this moment.
Thank you. So just to sum that one up then, adding another drug right now adds side effects, and we don't know that it adds much else. I'm putting words in your mouth, but that's now Christina, welcome back to the screen. Christina Sitt, as I mentioned earlier, is our programs manager at Lung Cancer Canada, and maybe I could just, before I pass it to you, Christina, thank you and Julie and Iwo and Darcy and Michelle and Shem and the staff at Lung Cancer Canada for facilitating and putting this on tonight. So thank you for that. And I'll pass it over to you to facilitate the Q&A.
Thank you very much. Thank you very much to our panelists, and thank you very much to all our listeners from across the country. And I actually see some international friends as well. I'm going to direct my questions to each of you. And for all of those that have put in questions in the chat box or actually sent them in earlier, there were so many questions. We are not going to be able to get through them all tonight, but we will try to perhaps ask the panelists to answer them later, and then we will post them up on lungcancercanada.ca. There are a few of you that have asked personal medical questions, and unfortunately we cannot answer your personal situation, but we will try to keep them to more of a general nature. So the first question I am going to direct to Dr. Melosky out in Vancouver, and there's been a number of questions on, is there any way to use diet and exercise or any way to prevent resistance?
Unfortunately, the short answer is no. I don't think we have any studies to show that diet can change cancer once it's arrived. Exercise, there is some data that's evolving. Some of it's in colorectal, some of it's in breast, to show that weight-bearing exercises can maybe even modulate your immune system. But I think that diet and exercise do something else. And I think that they make the overall person feel better. They give the mind a certain meditative feeling. They make patients feel positive about their bodies and themselves. So I would suggest exercise and diet are important, but unfortunately, I'm not sure if they can actually change the cancer.
So it may be contributing to your overall well-being.
Exactly.
So I'm going to go overseas now and go to Dr. Mock and ask, many of our patients are asking about complexities and what if you are both PD-L1 and EGFR positive, what do you treat first?
Right. So first of all, as I mentioned earlier, PD-L1 positivity, which means over 50%, is not necessarily the best predictor of response to immunotherapy in patients with EGFR mutation positive. There's one small study done in UCLA is that they have 12 patients that were actually both EGFR mutation positive and PD-L1 positive over 50%. When given the drug immunotherapy pembrolizumab, the response rate is 1 out of the 12 patients. So actually it's not that impressive. Secondarily, we are talking about a response rate of over 70% with the TKI. So I would certainly not use a PD-L1 as a first-line therapy, despite of the positive in the PD-L1 status.
Perfect. There's also a question related to, and because all of us are very, very young here, they're asking if you are been diagnosed with EGFR lung cancer and you're younger versus you're older, is there any difference in treatment approach? Shall we turn it over to Dr. Melosky?
Well, again, I think people who know me still think that I do think that when I talk to patients, I talk to them about sequencing. I talked to them about maybe an advantage of starting with afatinib, finding that T790, moving to osimertinib. I don't have that conversation with older patients, mostly because I'm not sure if they're going to get another line of therapy. And so I think that, I try to make decisions with patients. I try to, talk to them about the data, and I try not to bias, maybe, my own viewpoint. I think that, we live in a world now that, patients come into my office and they've got the recent New England Journal paper article with them. So, I think patients are knowledgeable. Webcasts like this, the internet, I think those are actually very positive, and I'm happy to discuss it with them. So I do think age does play into a role. I can give a 90-year-old osimertinib. I can't give that same patient afatinib.
Could I ask a little follow-up question then, Barb, about that? You'll give osimertinib to a 90-year-old, but not afatinib. Why is that? What are the differences in side effects between these different drugs?
So osimertinib is extremely easy, and I say that, but every so often I've got a patient who doesn't like it and has diarrhea. So I say it's easy, and the majority of patients, it's a really easy drug. Afatinib has its share of toxicity. It can cause diarrhea, rash, paronychia, certain nail changes. And so, it is more toxic to the patient than osimertinib. And so in older patients, that many of my patients are Asian, and the communication is not always optimal. And so osimertinib is an easier drug for them.
That's when you pick up the phone and you call Dr. Mock in Hong Kong.
Many of my patients do, by the way. There's many of my patients phone or somehow email or see Dr. Mock. So we share many patients. Kind of
hey, we're just one ocean apart, bro.
So, Dr. Mock, there's some questions that are coming in, and we actually have a lot of listeners here and attendees here that are not EGFR positive, but rather have other mutations, and they're asking about ALK and ROS. Are they like EGFR and they're not related to smoking as well?
Right, so ALK and ROS are not related to smoking similarly. However, the mutation type is quite different. It's not exactly a mutation per se, it is more something like a translocation. However, stay tuned for December. I'm sure that you have a program on ALK that will talk about ALK in detail. But I can just promise you there are great work and great study that have been done on this arena.
And thank you for doing our job in advertising for our next webinar.
I'm good at those kind of stuff.
I'm going to come back to Canada because there are a couple of questions related to Canada. Perhaps Dr. Wheatley-Price and Dr. Melosky either one of you can answer this question as that what are the next drugs that may be available in Canada that you think that Health Canada may be looking at?
Oh.
Well, so for EGFR lung cancer, which is what we're talking about tonight, really all of the drugs that we've talked about tonight are approved in Canada, and I think sometimes we complain that we don't have access to everything. And certainly at Lung Cancer Canada, we're continually knocking down the doors of provincial governments, federal governments, regulatory agencies to get access to drugs as soon as possible. But ultimately, we do quite well. So gefitinib, erlotinib, afatinib, dacomitinib, and osimertinib are all approved in Canada, and mostly available and funded across the country. The other drugs, the newer drugs, Dr. Mock mentioned capmatinib as one potential drug for c-Met, which is one of these resistance mechanisms. And some of the other drugs targeting C797S, the 4th generation inhibitors he mentioned, some of these antibody drug conjugates, those are all still in clinical trial in this situation. So they're not approved, and they wouldn't be approved in any jurisdiction, be it the US, Europe, or Asia, or here, until they've gone through those clinical trials. So I think right now we have access to all the approved drugs. And another, I think, good thing about Canada is we do attract a lot of clinical trials. And so if you're in the situation where you need a c-Met drug, it may not be available in your center where you're being treated, but it's quite possible that there will be another cancer center within reach where you could look to enroll on a clinical trial.
So we have 3 minutes left, and in the interest of time, I am going to ask one final question and go around to the panelists here. What is your vision of treating EGFR lung cancer in the next 5 years? How do you see that being treated? And let's start across the ocean in Hong Kong.
So we had taken a long journey of the 3 generations of drug. So the next step to ask the question is that how can we maximize the duration of treatment, or to manipulate it with all these different drugs we have to maximize the outcome for the patient? So one concept that we can engage in is something called the minimal residual disease, meaning that you start on a TKI, you want to see whether you're doing well before the tumor progress. So for that, we can actually use the plasma DNA to monitor the progress of the situation. So there have been data to show that if you take the drug, and then after a few weeks or months, that you still got EGFR mutation in your blood, then you're not doing well. The outcome will actually be less than what you expected. So maybe you can do something extra to those patients. So I think the so-called minimal residual disease, or monitoring of the EGFR in the plasma DNA, probably may come into the clinical practice in the near future.
So I'm going to go across the ocean, and Dr. Melosky.
Well, I think if we start treating adjuvant treatment, and we start finding patients at surgery who are EGFR positive, and they won't come to the metastatic stage. I believe that it's going to cure patients. I think that we're making family doctors aware. They're starting to think about lung cancer in patients who have symptoms at a young age, even if they don't smoke. And so I think that education has actually paid off. I think all of them have heard of this mutation called EGFR. So I hope that I see less patients in the future. I hope we cure more patients in the future. And I hope in those patients that are on EGFR inhibitors that they continue to live a longer life with high quality of life.
And the word cure is what all patients want to hear. Dr. Wheatley-Price, over to you.
Yes, what they said. Basically, I think, you're right. Firstly, we want to improve the cure rates, which means catching cancer early. And so a little diversion from EGFR positive lung cancer, but we really would like to see lung cancer screening being available across the country to detect lung cancers early. Not all of those are likely to be EGFR positive, but some of them will be. And then we can improve the cure rates with drugs like osimertinib. And maybe just to close off that, I'll tell you a story about a patient that I've been seeing for a number of years. He's well known to the Lung Cancer Canada community and has even come to Parliament with me on occasion. And he was diagnosed quite some time ago, before osimertinib was available, and he was on gefitinib, and it lasted long enough for him to keep him well and healthy So when the time came that he did need to change, osimertinib was available. And so he was then being able to be on osimertinib, and that has worked long enough to keep him well and healthy for long enough that now when he needs a change, we've identified the CMET, and he's going to be able to go on a research study for that. And so these drugs are now helping people to sort of be well enough for long enough that then the science can keep up with them and we can move on to the next stage. So I would like to see that continue, and with some of the science that Dr. Mox outlined just there.
And so on that note of hope, I'd like to thank the panelists and also tell everyone that we are just in the middle of our Lung Cancer Awareness Month right now. Throughout this entire month, we have other events and other things that are ongoing that we will hope that you will join us. One, we have a t-shirt contest. You guys have been asking us for a t-shirt contest for many, many years, and our t-shirt design contest is now open, and submissions are open until November the 23rd, at which time we'll open it up nationwide and ask you guys to vote for your t-shirt, and the winner will be announced at the Evening of Hope. So I encourage all you artists to join that contest. The other thing that we have ongoing is what we call the Hope Army. Now, for all of you listeners out there, if you believe that lung cancer patients deserve a voice, if you believe that lung cancer patients deserve equity and don't deserve to be asked the wrong question, then please, you are a Hope Army recruit. Join Hope Army and help us choose your own mission. We will ask you to help us with increasing lung cancer awareness and sharing the voices of those living with lung cancer. For those that want to go to Parliament and also make your spread your awareness amongst your elected officials, we have tools to help you do that too. So join Hope Army, increase the voices of those living with lung cancer. And for those that do, we will send you this mask. And you can put it and wear it and proudly state that you are a Hope Army recruit.
My name is Parisa Sapiri. My mother is a 5-year stage 4 lung cancer survivor, and to me, hope is the voice that reminds you that life is full of so many great experiences and that there are many more to come, even if right now it's a little bit difficult to see that.
Thank you, and I turn it over to Dr. Wheatley-Price for some final words.
Yeah, thank you all for joining. Thank you to Tony and Bob for really that wonderful expert knowledge that you've shared with us. And we're really thrilled that on this inaugural What's New in Lung Cancer series, we've had such a panel. So thank you both very much. Our next What's New in Lung Cancer webinar is on December the 3rd with Dr. Camage and Dr. Lale. That's going to be about ALK lung cancer, and you can get details and register on the lungcancercanada.ca website. But thank you very much, everybody. Tony, for getting up early in Hong Kong. You can now go and have breakfast, and I'll go and have dinner. Thank you.
Thank you so much. Send me the t-shirt, size small, please.
Will do.